Welcome. Today we examine the critical synergy between diagnostic stewardship and antimicrobial stewardship. We are moving beyond the era of prescribing by symptom into an era of precision. To effectively combat AMR, we must integrate infection prevention, antimicrobial therapy, and high-fidelity diagnostics into a single cohesive clinical strategy. The stakes are staggering. By 2050, AMR could cause 10 million global deaths annually. Since the 1950s, doctors have largely prescribed based on immediate symptomatic assessment, what we call prescribing in the dark. Diagnostic stewardship is the engine required to move from guesswork to evidence-based precision. Stewardship is a continuous clinical loop centered on the healthcare provider. While ASP focuses on the output, the right drug at the right time, DSP manages the input, the right test for the right patient at the right time. Microbiology serves as the engine, performing rapid tests to generate the data that drives clinical decisions. We trace the signal through the noise across three phases. Phase 1 is the pre-analytical bedside, where the focus is patient selection and sampling. Phase 2 is the analytical bench, focused on calibration and rapid analysis. Finally, Phase 3 is the post-analytical return, where results are translated into clinical interventions. Bedside success relies on rule number 1. Specimens must be collected before the initiation of antibiotics. A compromised sample guarantees compromised treatment. Clinicians must ask 4 crucial questions. Is an infection truly suspected? What is its nature? Which tests are the priority? And exactly how should they be collected? For systemic infections, timing and volume are critical. Collect blood cultures at the fever peak, using a one-step CHG alcohol disinfection and a dedicated sterile tray. For respiratory samples, the gram stain is the gatekeeper. We accept sputum with more than 25 pus cells and fewer than 10 epithelial cells per low-power field to ensure we aren't testing saliva or contamination. Slide 7. Specimen Pearls, Urine and Enteric. Diagnostic stewardship means knowing when not to test. Do not screen for asymptomatic bacteriuria except in pregnancy or before urological procedures. Cloudiness or odor alone are not indications for culture. For C. difficile, only test watery, unformed stools, Bristol type 7, and cancel orders if the patient has received laxatives in the past 48 hours. Slide 8. Phase 2. The race against time. Phase 2 is the man versus machine challenge. Traditional methods often involve a 72-hour wait for actionable data. Rapid molecular methods shift this timeline to day 1, allowing for immediate de-escalation. However, these diagnostics only decrease uncertainty if they are actionable and tied directly to an active stewardship program. Slide 9. The Rapid Diagnostics Arsenal. Our arsenal includes 3 main technologies. MALDI-TOF provides identification in roughly 30 minutes, but requires a pure colony. Multiplex PCR identifies pathogens and resistance genes, like MECA or KPC, in 1 to 4 hours. Finally, POC NAAT offers bedside triage for flu, RSV, and COVID-19 in under 20 minutes. Slide 10. Turnaround time versus intervention. We must distinguish between turnaround time, TAT in the lab, and time to intervention, TTI, at the bedside. Rapid diagnostic results must be reported and interpreted by the ASP team to adjust therapy at the earliest possible moment. This proactive intervention is what translates laboratory speed into improved clinical outcomes. Slide 11. Phase 3. The ultimate clinical filter. The greatest danger in the post-analytical phase is climbing the wrong tree, treating a lab report rather than a patient. A lab report is data. A diagnosis is a clinical decision. Clinicians must act as a filter, using the patient's temperature and symptoms to differentiate harmless colonization from true pathology. Slide 12. Bedside Reality Check. Treat the patient, not the device. To halt AMR escalation, we must stop pan-culturing patients on multiple devices without clear indication. The mandate is simple. Treat the pneumonia, not the endotracheal tube. Treat the UTI, not the indwelling catheter. Treat the bacteriuria, not the catheter tip or hub. Slide 13. Unmasking device-associated infections. For CAUTI and VAP, all clinical, radiological, and microbiological criteria must intersect. A positive endotracheal aspirate culture is highly sensitive but poorly specific due to rapid colonization. A valid diagnosis requires the presence of clinical symptoms, such as new persistent infiltrates on chest X-ray or altered mental status, to justify treatment. Slide 14. The collaborative ecosystem, a culture of cultures. Diagnostic stewardship cannot happen in a vacuum. It requires a collaborative ecosystem where clinicians provide accurate context and targeted ordering. In return, microbiologists provide selective reporting, hiding known contaminants like cons, and cascade reporting for reserved drugs. The first step in any post-analytical phase is talk to your microbiologist. Slide 15. The verdict. In summary, you cannot optimize the drug if you don't optimize the data. Prioritize pre-analytical collection to avoid garbage in, garbage out. Remember that speed is a tool, not a cure. Learn to filter the noise of colonization, and above all, communicate. Collaboration is the cure for diagnostic uncertainty.